All right, so we're recording now. All right. So shared a little bit about access. Again, we are a program of Cal Voices and a consumer-led advocacy program funded by the MHSOAC and Prop 63. A little bit about our organization. Cal Voices was founded in 1946. We are just over 70 years young. We are the oldest continuously operated consumer advocacy agency in California, and we are a peer-run organization, which means we specifically hire individuals with lived experience of mental health, mental illness, and recovery. So ACCESS is an acronym for Advancing Client and Community Empowerment Through Sustainable Solutions. That is a mouthful, so you may call us ACCESS for short, but everything that we do is about elevating the voice and choice of individuals receiving services within the public mental health system. And we just really want to ensure that we let the public mental health system know that our values are critically imperative when implementing programs, policies, and providing services throughout the state. So we really want to ensure that there's meaningful advocacy across the state. And really what that means is that we have meaningful stakeholder participation and active solicitation of community feedback, as well as expanded opportunities for involvement and inclusion at all levels. And so a lot of times when we think about advocacy or the community planning process, we're really thinking about coming together and brainstorming or sharing ideas of what we would like to see funded. But it really, the MHSA calls for individuals to be involved at all levels of the process, which includes policy development, program planning and implementation, service delivery, oversight, and administration. Another value that is critically important to us is recovery, and we want to ensure infusion of recovery principles in all aspects of service delivery. We also want to ensure that we're tracking and reporting and that there's meaningful analysis of recovery outcomes in mental health programs, right? So we really want to know what programs are producing the most meaningful recovery outcomes. So those are the programs that we're investing in and expanding upon. And then lastly, but definitely not least, is peer support. We want to ensure fidelity to the evidence-based model and incorporation and expansion of peer providers in all mental health programs and at all levels. We want to ensure that peers are being provided living wages and ongoing professional development, as well as opportunities for advancement. So today, we're going to learn about our 2019 State of Recovery Oriented Services. We did a lot of research and data collection to see where we are currently within the state of California. We're also going to learn about the client and leadership perspective as it relates to recovery and measuring recovery outcomes, as well as pitfalls of recovery-oriented services. With that, I'm going to pass the baton over to Noah. Take it away.
Okay, thanks everybody for joining us today. We do have a lot to cover and the material is fairly dense on the slides. So what we're going to do is kind of maintain a 30,000 foot level perspective and kind of understand recovery oriented measurements as a whole and where it is and how it relates to California mental health services. There's again, a lot of detail on each slide, but it's there for your reference and it's available for download as well if you'd like to use it as a reference sheet for any type of other advocacy in your county or your space. So we have 4 sections for today. We're going to do, as Andrea just said, the current status of it, of where we are with measurements, the client and leadership perspective, measurements of recovery-oriented outcomes, and pitfalls and of recovery-oriented services. We're going to stop at the end of each section to be able to take a few key questions from participants. And if there's clarifying issues, please put them in the chat box and we'll try to address them as we move along. And so again, the slide says, where did we start? So recovery is kind of a squishy element that's hard to measure and hard to kind of get your hands on or a grasp on because of the differences between services being done in a medical model or a recovery-oriented model. So is it a journey or is it a destination? Is someone in recovery or are they recovered? A lot of the times, I know that clinicians look to mitigate symptoms as a means to say this person is recovered. But living in recovery is something much more complex where they have a stable lifestyle. There's a little bit more of a normalcy or a culture of preferred behavior that they feel better about themselves and how they're feeling about the world in recovery. And that's kind of where we're looking. So creating recovery outcomes is a little bit of a difficult element, but we're going to start with what Dr. Mark Ragins did in MHALA or the Village in the 1990s, as well as what he kind of produced after the MHSA was written. So starting in the this is all material that was presented in last year's annual conference. So this is, again, going over our State of the Community report and Milestones of Recovery that Dr. Ragins presented on. So the material is there from the 2019 conference on our website, and then in a little bit greater detail. And then, so we're just kind of redistributing this information to refresh your memory as far as how we all understand it. So in the 1990s, Dr. Mark Ragins was kind of a pioneer as far as developing recovery-oriented programs, and the way that he to measure outcomes for his clients that were in the process of recovery. And those were elements that were considered the quality of life outcome domains that included residential residential qualifications, employment, educational, legal, financial, conservatorship, payee, incarceration, and hospitalization. Now, those are elements that he thought related more to a quality of life or a standard that would be different than kind of the numerical quantities that are measured in medical outcomes or medical model procedures. So it's about looking at a whole perspective and a whole person rather than kind of the smaller elements or the consequences of symptoms or the consequences of living with mental illness. And so the quality of life outcomes were something that was to build upon. So where are we? And that was in the 1990s. And so where are we now in 2019? We started with the 2019 State of the Community report with one of our couple of key questions, including what do clients need to recover? And this went out to clients, family, and leadership as far as how they wanted to respond according to survey options. And then there's also what are the MHSA recovery-oriented mandates? And what are the services in the public mental health system meeting clients' recovery needs and the MHSA recovery-related mandates? So those were our key questions that we wanted to explore in our year 2 survey system. We got about over 600 respondents, so we feel that it's fairly representative of clients, family, and leadership. And so we'll start with the first one. We're not going to go over all 3, but we will address a few of them. Again, trying to maintain a higher level understanding of and generalizations about recovery-oriented measurements. So what do clients need to recover is where we started, and Next slide, please, if you could, Andrea. Like I said at the beginning, it's kind of a squishy element. So what is recovery? So for our survey and for other elements, we stick to the SAMHSA working definition of recovery, which is a process of change through which individuals improve their health and wellness and live a self-directed life, strive to reach their full potential. So there's 4 major dimensions and 10 guiding principles. And you want to start with the 4 dimensions and kind of work your way down into the 10 principles that fit into those things. So we have the 4 major dimensions, which are health, home, purpose, and community. And those are, you want to click through the rest of those so they can see the specifics. So the health, of course, refers to physical and mental well-being and the alleviation of symptoms and a comfortable lifestyle. Home refers to a stable place to live. Purpose, daily activities, jobs, schools, volunteerism, family caretaking, and creative endeavors that kind of set up a normal routine or a schedule that someone feels comfortable with or maintain a little bit of structure. And then, of course, community is about the relationships and social networks that provide support, friendship, love, and especially hope in the process of recovery. Next slide, please. So as I mentioned, this is traditionally contrasted with the medical model, which is with the goal to treat an illness. So these elements can be very quantified as far as how it relates to a person with lived experience or going through a process of recovery in the terms of how many hospitalizations were there, how many days of distress were there, but it doesn't actually look at the whole person as far as how they're feeling about their life, what makes them feel good, what's their comfort level about being at their home, are they feel safe, are there places that they want to be in that they can't get to yet, or these types of things that really don't fully capture the element of recovery. So, but it serves its purpose, and we'll get into that in just a little bit because there are goals and reasonings for quantified measurements as well. And then on to the next slide, please. So
I just wanted to echo. Can folks hear me? Can you hear me, Noah?
yeah.
Okay. I did want to say that one criticism of the medical model in recent years, consumer advocacy groups have expressed concerns related to how clients are classified, and many take exception to terminology that seems to put them in a box with a label that follows them through life, and that does not capture the fullness of their identities. So I think it's important for us to be mindful of, the labels as well that go along with this.
Thank you, Andrea. So with the medical model, you can see that kind of in that reference is that a diagnosis almost encapsulates the whole essence of the treatment or the way that the person is identified. They're a person with schizophrenia, they're a person with depression rather than a person going through mental illness or going through a process that's just out of the normal sense of things. So move on to the next slide, please. So with recovery model, the goal is to improve lifestyles. Recovery includes a subjective manner, which is kind of a way to say that it's not exactly quantifiable, that it depends on the person that's interpreting the way recovery is being done or recovery is happening. So to say that someone is stable in their home experience is subjective to the person that's providing treatment or providing peer support services. Someone might say they're doing really well, and someone might say they're doing really bad. But that's why that's why it's always had trouble being measured. But there are ways around that, and we'll jump into that in a moment. So with the recovery model, again, you're looking from the person onward with all their types of personalities and skills and elements of lifestyle, their recreation, their culture, their education, their means of transportation, their sense of empowerment. What are those things that are really kind of strength-oriented, strength-based, and the way to really impassion a drive towards recovery, in recovery? And those are the elements that kind of move one person or move most people into a state of recovery.
Thank
And
you, Noah. So before I move on to the next section, we're going to get into the MHSA recovery-related mandates. I am going to go ahead and unmute everybody to find out if there are any questions or any comments at this time. So everybody, you are all unmuted. Okay, Noah, I'll go ahead and place everyone on mute. And just one moment, I want to make sure I don't mute you in the process. And just to let folks know, we will be pausing at the end of each section to provide time for questions and comments. Noah, passing the baton to you.
thank you. So what are the MHSA related mandates? This is where we're going to kind of stay at a high level. We were able to recognize that there are 5 elements in the both legal code, the Wellness and Institution Code, as well as the Code of Regulation, California Code of Regulations, that specify recovery-oriented systems or recovery orientation as far as mental health services. We're gonna, on to the next slide, please. We're gonna address 2 of them, 3 of them very specifically with the MHSA general standards. Of course, it includes the client-driven perspective, as well as the wellness, recovery, and resilience focus. Those are the two general standards that stand out as far as incorporating recovery-oriented principles into the MHSA code and legal code, law and codes of regulations. Next slide, please. So client-driven is very specific to say that the clients are in the driver's seat, and that means that they're the primary decision-making in a primary decision-making role as Andrea said, in policy implementation and planning and evaluation and budgeting and things of that sort. That's really important to allow a client-focused perspective both drive the system as well as their personal recovery. So it comes from the treatment system that is about a client choosing what they want to do to focus on and prioritize in their recovery, but at a systemic level so that they're able to say, these programs work for me, or when I prioritize this, my recovery is stronger. And that's the way that we create systems of recovery-oriented structures in a systemic level across the state in both planning opportunities as well as implementation. And and we're gonna keep moving through the next 2 slides. So then we also touched on wellness and recovery and resilience focus. So there is in the Welfare and Institutions Code a priority to say wellness, recovery, and resilience focused as far as the programs and the programs and policies for the MHSA. And this is a requirement. If you'll notice, the language says planning services shall be consistent with the philosophy, principles, and practices of Recovery Vision. That is a mandate rather than an option. And the next slide, please. And there are requirements for SFP data collection requirements that include some elements of quality of life, like Dr. Ragins had put out in the 1990s. that include residential status, educational status, employment status, legal issues. And then there's also some of it kind of goes back and forth between the quantitative medical model that include administrative data excuse me. These are all the FSP recovery-oriented measurements that are in the Code of Regulations right now. And
I just wanted to add to that. One of the reasons why we're sharing this particular information with you regarding the FSP data collection requirements is because although the MHSA calls for meaningful recovery outcomes, the only area within the Act where they actually have a bullet point list of areas that are to be measured and actually tools to provide to local counties on how to collect FSP data requirements or FSP data collection around the recovery requirements. Counties are not given the same tools for all the other MHSA programs. So again, this is only for the FSP programs. And so counties are left to their own devices to determine what data collection tools they choose to implement to track recovery outcomes. And I think that's been a real challenge, and counties would benefit from additional support from the state because again, as Noah was touching on earlier, tracking recovery outcomes can be subjective, but we are finding ways, and there are many tools out there that can be implemented, but I think that we need to provide a little more support around that on what tools to select and who's going to be collecting that data and who's going to be reviewing it. And again, if we go back to the MHSA, it should incorporate clients in that decision and clients in the review process. So Noah, back to you.
Thank you. I did see a question in the chat box to speak a little bit more about the community collaboration. Thank you, Vernon. This is kind of, so the recovery-oriented system is a set up for a treatment process as far as how to create qualitative measurements and qualitative behaviors that aid recovery and encourage a process or sustained recovery. The systemic level and the appreciation of recovery-oriented services and that perspective that was brought together from the consumer movement in California was the importance of collaboration with stakeholders as the driver and the client-led perspective, so that like a treatment process where the client is choosing what to focus on, therefore stakeholders are choosing what to focus Mental Health Service Act dollars upon at the community and statewide level.
I also see that we have a hand up. Is it Daniel McFadden? I'm going to go ahead and lower your hand, but you're on. Daniel McFadden. Okay. Looks like you may not have a mic, so feel free to incorporate your question in the chat box, or if you're able to get a mic, we'll come back to you, so you can raise your hand again. All right. Anybody else? I'm going to go ahead and I'm going to open it up. No, I'm going to unmute everyone and move to the next slide and give folks a chance for question and comments.
Good morning, Noah. This is Vernon from Humboldt County. Andrea, how are you doing?
Hi, Vernon.
I would like to inquire more in depth of what Noah just said about community collaboration and the participant or consumer's involvement in setting forth the needs of a community to be addressed. I can specifically speak on the Superior region, not just here in Humboldt County, but with lived experience in multiple counties in the state of California, that even whether it be a one-person voice that's speaking for others that are afraid to speak, or a group of consumers or participants of the public mental health system. Uh, those voices are not all, but a good percentage circumvented through administration of a county that says, well, we've either tried this in the past or we don't see this working. How would it be? What would your suggestion to be to uh, better approach this in a more productive and proactive way than to just become passive and or to allow a group of people's emotions to become overwhelming to even probably say something inappropriate in a meeting setting? Can I get some advice from our leadership here from Access today?
So I feel I want to make sure I'm clear on the question at hand. So
Yes, ma'am.
pertaining to collecting meaningful recovery outcomes and basing program decisions on those outcomes, is that correct?
Well, we can't get outcomes if it's not going to be a pilot project or to even be thought of being implemented. So without the implementation of that, then we can't collect the data. So
So
it's circumvented. It's circumvented before it ever gets started.
I apologize. I didn't mean to talk over you.
No.
I do want to say that for the sake of this webinar, we're really talking about recovery, tracking recovery outcomes
Mhm.
for systems and programs that are currently in place. And so the MHSA is calling for meaningful recovery outcomes. And so therefore, we need to ensure that we have meaningful recovery outcome tools that are client driven. And so we're really talking about, encouraging counties to adopt these tools in partnership with their clients and community stakeholders. Now, what you're talking about are programs that aren't in existence, and so that might be a sidebar conversation that I would be happy to have with you. Does that sound good, Vernon?
Yes, and yeah, it would probably be best for us to have a side conversation because I understand that my vagueness, maybe need to be more precise and zero in on this. Some of these programs are already in existence to where the consumer voice is circumvented at the senior program management and above. And this is very frustrating to those consumers that want to have a voice. But at that point, once they're shut down, they don't know where else to turn other than the passive stage. So if we could probably talk later on today or next week, that'll be great.
Absolutely, would be happy to. I also see a comment from Teresa Comstock, Director of California Association of Local Behavioral Health Boards and Commissions. And if you can all go to your chat box, she has shared a link. She said there's some really good performance outcome data reports for Humboldt, Vernon. So you may want to refer to that as well. Okay, I'm going to open it up. Is there anybody else that had any questions or comments before we move on to part 2? Okay, well, there will be opportunity again moving forward. I am going to go ahead and place everyone on mute. And Noah, passing the baton back to you.
We're going to kind of fly through this second part about the client and leadership survey. The questions that we jumped into were specifically our services in the public mental health system meeting clients' recovery needs and the MHSA recovery related mandates. So this was a survey, again, that went out to over 600 participants. And so we feel like it's fairly representative of clients, families, and leadership responses. We're going to focus specifically on the client voice today because that's our role. Many of those, the top 6 elements that were listed were in relation to the kind of core 4 principles of recovery, which were home, community, health, and purpose. And this was representative of both clients and families of what they said were most necessary for achieving and maintaining your recovery. And so you can see that there's a kind of an intuitive understanding of what it is that makes that feels healthy about recovery. And then there's also the negative side, which is the lowest scores were preventing hospitalizations, the minimizing or eliminating alcohol or substances, and resolving any outstanding legal issues. So you can see that like the contrast between how recovery-oriented systems are a little bit more intuitive through the lived experience perspective rather than the measurement perspective. And then also, which are the following factors or were important in your personal recovery? Again, these are the core four that are home, community, health, and purpose, as far as, and then hope and optimism, which are key to driving a process of recovery or at least getting it off on the right foot. Now, again, we are focused only on the client perspective, so you can see that this is what clients said were being asked of them in their treatment process or in their sessions with clinical supervisors or service providers. So there were over 70% of people say that they are asked about their community, their purpose, and if their provider believes they can recover. And that's all very, very positive. That there are still fairly high scores for home, health, and resources, but they lagged as far as being above that 70% watermark. What we don't have here is that many of the leadership responses actually said that they weren't sure if their services were being provided or they were asking the right questions as far as recovery-oriented services. So it's hard to draw conclusions as far as not sure or don't know, but it is alarming to say that it wasn't in a specific training to say these are the things we need to focus on for recovery purposes. And we're going to jump into the milestones of recovery here. Do we want to pause for the survey questions or questions about the survey?
All right, everybody, you are unmuted. So are there any questions? If there are. No questions or comments at this time, I'm going to go ahead and place you all on mute. And then we will go ahead and move into part 3.
So part 3 is part of Dr. Margaret Ragins' Milestones of Recovery presentation that was at our 2019 annual conference. So his was very in-depth and about a 2 to 3 hour long plenary session, but I kind of took out some of the highlights and kind of specified where key points needed to be made. So the MHSA was supposed to be an expansion of programs that were developed out of AB 2034, and that was actually very specific to the quantified measurements that were outcomes from AB 2034 in LA County. So this is when quantified and specific measurements are optimal to be able to say these outcomes were a 59% decrease, an 87% decrease, a 73% decrease, and a 275% increase in employment days. So like there is a point to quantified statistics and quantified measurements, and that's actually what helped the foundation of the MHSA be so strong in the expansion of AB 2034 data. And so jumping into the next slide.
So before I do that, I just got a comment that I didn't give enough time for folks to respond for questions for the last one. So I just want to pause real quick, and I'm going to unmute you all again. And I saw Pasha, your hand was up. Go ahead, take it away.
So this is Pashi. Can you hear me?
We can, yes.
Awesome. Can we go back to the previous slide?
Absolutely.
Well, actually, there we go. So I hate to be a research wonk, and I apologize, but Noah, you keep saying that this was a representative finding from, I think, consumers and family members, and you mentioned the number 600, and I'm just wondering that the way that you reached out to people and who filled this out, have you compared it to more general public to make sure that you had representation from different races and ethnicities, whether you had representation from different LGBTQ communities? I just want you to be careful. These are your findings from the people who participated in your survey. That's absolutely true. But if you're saying that this is generalizable to all clients, consumers, and family members across California, I just want to clarify which statement is more accurate.
Pashi, I appreciate that question, and I really stand behind the survey and the validity as it speaks to as being a representation of our diverse community stakeholders. So those individuals that completed the survey were representatives from all 5 of our California MHSA regions. These were incredibly diverse communities. The surveys were not only completed by individuals who are on our distribution list, but we also did multiple trainings for stakeholders in all 5 regions across the state. And we did leadership roundtable focus groups as well as stakeholder roundtables as well. And so we were really able to get a diverse sampling, and that is what informed this. So this is individuals with lived experience. We have interested community stakeholders, clients, family members, state leadership, and local level leadership. So again, it was a really broad sampling. So, but thank you for your question. And with that, I don't want to go too quick, so I really want to pause and see if is there anybody else that had any questions. I do see that we have a Yolanda, your hand's up.
Yes.
You're on.
Thank you. Can you hear me?
Yes, we can.
Okay, good. This is really a question for at the end, so you can save it at the end to answer. But before I forget, this survey was taken before COVID-19. How are all the measurements going to be affected for since February of 2020 through until the end of the pandemic, or until we find a vaccine or something? It's going to affect the measurements a lot, I would think, because so many people have had to stay home.
Right. I'm sorry, Yolanda, you cut out just a little bit. You were saying about the survey was it was conducted prior to COVID.
Health
Absolutely.
include a person's issue with food?
Yes, that's what I'm saying is everything's changed, and it's going to affect all these results that we're getting from prior to
Absolutely.
January of 2020. And so are we going to
Absolutely.
redo this survey to really see what's happening now currently? Because as one gentleman just pointed out, there's food, there's housing issues, there's quarantine, there's inability to get to your provider, people can't teleconference, people can't phone conference, there's all kinds. And then providers are also having to stay home if they have compromised immune systems. So there's a huge problem there that I know our Siskiyou County board is really addressing currently.
Absolutely. Really excellent points, Yolanda. And I would love to continue that conversation at the end as well. And I would love to hear from you more about how Siskiyou County is tackling it too.
And I said this question can be held until the end because we haven't finished the presentation.
Absolutely.
And it covers the whole presentation.
Thank you,
Thank you.
Yolanda. I appreciate your question and your feedback. Is
You're welcome.
there anybody else that has any questions or comments at this time before we proceed?
That was good.
Yeah.
Okay. Okay, if there's no questions, I'm going to go ahead and just place everybody on mute, and then we will open it up again at the end. And with that, Noah, you are on.
Thank you. If we could jump to slide 31, I want to say. That's where we left off. And so, again, one of the things that Dr. Ragins mentioned is that with the subjective manner of recovery and the idea of being able to, this being a soft, squishy thing that's hard to measure, we're not actually looking to measure recovery itself. It seems almost impossible to measure recovery itself, but we can measure things that are correlated to it. And I heard a great kind of phrase that was put out by a data scientist was that, you know, most of the time we're not measuring the specific element that we want to know about. Like even with weight, you're going to stand on a scale and it's not going to know your exact weight, but it's going to measure the distance that springs decrease or expand according to the gravity that you put onto the springs. So it's not something that's actually measured your weight, but it's the correlation about the spring change in springs or the correlation change in things related to that element. So it helps find things that are correlated and specific, but not actually so representative of recovery itself. So next slide, please. We're gonna, one of the things that he came up with after the quality of life measurements in the 1990s was the Milestones of Recovery scale. And this was the things that were observable correlations of recovery, which included the level of risk, the level of engagement, and the level of skills and supports that were developed through the process of recovery. And there are different elements that you can measure in a quantified scale to say that they're to measure the difference between someone at extreme risk or as legal code puts it, a danger to themselves or others, or not able to care for themselves, gravely disabled, or things of that sort, to all the way, and you can see the different variations: high risk, not engaged; poorly coping, engaged; coping, rehabilitating, and then all the way up to advanced recovery. So it's a quantified measurement and milestones that are numerated so that it's quantifiable and can be measured and put into a number of different data sets in a systematic way. So the graphic that he provided was this one. Back to the milestones of recovery, if we could, was this one where it's not going to be so specific to say that it's a streamlined process that everybody goes from 1 to 8. But you might go from 1 to 3 and back to 2, or you might go from 5 to 6 and back to 3. And it would be numbers or quantified measurements that are specific and representative of correlated risk and behaviors and coping and recovery system and advanced recovery. And that's the way that he chose to use the milestones of recovery to establish a system that went from risky behavior and extreme risk to coping and engaged and participatory in the recovery to learning supports and systems and not being needed to be cared for, but moving towards independence and advanced recovery. Next slide, please. So with the milestones of recovery, you can kind of predict as long as you have a large enough data set. So it would take time for these to be implemented, and it was done at the MHALA, the Village programs, but it needs to be done on a broader scale and to be able to create predictive algorithms for when someone reaches level 6, is there a risk to go from 6 to 3 or 6 to 5 or 6 to 2, depending on the level of engagement or the subjective nature that is measured by the provider or peer support specialist in their sense of risk, coping, and independence. So on to the next slide, please. So again, there's a lot of detail in these slides and they're available for your reference. And so the milestones of recovery are based on needs determination. So what are the primary processes that a recovery system goes through with a provider and consumer relationship? So you want to establish the risk reduction and then get them engaged in their program and their client-driven perspective of what they need for their personal recovery. And then you want to work on motivation and then full engagement and motivation that builds skills and supports to aim towards independent living and away from a caring model of providership, but onto a more coordinated skill level of independent living and self-reliance. And then the milestone of recovery number 8 is a self-directed full recovery or sustained recovery. On to the next slide. So again, these are the service needs that are met with the and the different quantified numbers. In the full presentation from the annual conference, he put together a number of different data sheets that were exemplary of how the milestones of recovery can be utilized and put into spreadsheets and systems that that coordinate the data and the measurements on a subjective manner, yes, but in a very coordinated manner to say that we're looking at the lifestyle of recovery rather than the quantified numbers of treatment reduction, of symptomatic reductions and days in hospitals and things of that sort. So next slide. So this was the person-centered levels of services, because recovery-oriented services are not just about the service provision, but also about the type of space that it's in. So, I'm getting ahead of myself. So you can see that the person-centered levels of services are, again, with that client-driven perspective. So it's a person-centric to look at what are the systems that the settings that they're placed in, how are they working within those structures or systems or institutions, and it gives specific detail as far as the spectrum that is necessary to evaluate a variety of different people through a person-centric and subjective lens as far as how they might be recovering. Next slide. So one of the things that it was an emerging problem for the milestones of recovery was that there wasn't enough difference between growth and caretaking. And this was with the best of intentions from providers to say, I know what's right for you, or I can do it for you, let me do it and you'll be fine. But part of growth and part of independence is to learn skills and supports that are able to develop independent living so that you feel comfortable in your own skin, you feel comfortable doing your own daily activities, how to get to work, how to get to your volunteer opportunities, how to find your provider when you need them, those things of sorts that are really built on skill development rather than supports that were provided for you. And again, that's really trying to stay pertinent to the person-centric and client-driven perspective to say, these are the things you need for yourself to do better by yourself. And we're going to help you get there. You're not going to do it alone, but we're going to help you get there by developing skills and supports. So thank you. We are on the stages of recovery and the caretaking services. You can see, again, this is to provide that the levels, the stages of recovery, and are based upon a spectrum. So you can, although they're subjective, there are still specific points that fit within a quantified 1, a quantified 2 or 4, or a quantified 3, 5, or 6 as far as being engaged but poorly self-coordinated. So that you can say that although they have structure, they're still not fully engaged in doing it for themselves and things of that sort. So, and then there's also the determinants of care, which is going to be a little bit more of the support, what does the person need staff support for, managing medication, managing money, managing transportation. And those determinants of care create a systematic spreadsheet. If you want to go on to the next slide, there's a matrix that shows how the determinants of care, or the determinants of care and the milestones of recovery create a systematic way to say, this is the level of care that somebody needs, or this is the level of care that somebody is moving on to. This is the level of care that they're taking a step back from, because we all know that recovery is a process that goes both forward and backwards, and hopefully overall in a forward direction. Again, there's a whole lot more in the original presentation materials from the annual conference on our website. And so I'll just kind of jump into these things as well. One of the things that he said is that you're not really a recovery program. You just changed your signs and your charts. You're still hiring the same old people and do the same old things. And that might be something that we hear quite a bit about our current system. And that's because a lot of the culture for service provision hasn't changed. And so the recovery-oriented and wellness-focused mandates that are in the MHSA general standards is a part of that. And so the milestones of recovery also and recovery-oriented measurements can be adapted for, not the milestones of recovery, sorry. The recovery-oriented goals can be adapted for service provision as well. And if you go to the next slide, there's a spreadsheet that shows where a service provider is growing or exploring, engaging, mastering, or excelling in different things that are welcoming to clients and consumers, or those that provide how they provide walk-in services or after-hours services and things of that sort that actually elevate the way that service provisions are being made to become more recovery oriented. And this is a scale that says exploring, emerging, mastering, or excelling. And one of the big things is being welcoming, and then also the involvement of consumer and recovery principles. I think is that the end of that section? Yes. We have about 5 minutes left. I'm going to jump into the pitfalls real fast because there's only 4 of them, and we'll just highlight what they are, and then we'll take some questions. Pitfall number 1 is a clash of cultures. With recovery-oriented measurements, you're dealing with data people, and data people love quantified, hard numbers that are able to say, that go up or down, that are structured, that are quantified, that are put into percentages and statistics, and choosing to measure quality of life versus the quantified metrics is a very hard clash of culture to overcome. Go on to the next one. The pitfall number 2 is that the data is still a little bit subjective, and how do you trust the data that you're using? There can be different types of motivations to say why a client is behaving a certain way or engaging in a certain way, which could be to avoid punishment, seeking reward or self-reward, or higher principle or value. So it's not, because it's still subjective, we don't know the true motivations or the direct correlations or causations of these measurements. But taken together, they are all correlated and point towards recovery outcomes. Pitfall number 3, we're competing with a very powerful medical model payment system, which is the structure of Medi-Cal and the publicly funded mental health system. And then many people aren't really promoting recovery systems. And that's what we got to at the end, is that even service provision can look towards recovery-oriented service provisions to better meet the needs of both legal needs of the MHSA mandates, as well as the client needs of recovery-oriented systems. And that's what I got. Any questions?
All right, you're all unmuted. This is your opportunity to ask questions or provide any comments. I will say that in response, Yolanda, to your valuable question and observation, I really appreciated Pashi's response, and it's kind of what I was leaning towards in my thinking as well, is that yes, you know, our landscape is completely changing, right? We're in the midst of a pandemic, but I would think that COVID would affect how at risk or in recovery someone is, but not necessarily change the questions one would want to ask. And the examples given were housing stability may have changed due to COVID, but asking about this housing stability would not change. And I echo that, and I think that's a really great point. Thank you for sharing that, Pashi. With that, are there any other questions or comments? Yolanda.
Oh, it's Yolanda. I agree with what you said. I was more looking at the statistics. I can never say that word, maybe because I never took the class. But looking at the outcomes when you do surveys and stuff, because it's going to change a lot of stuff. I mean, Siskiyou County is doing teleconferencing, video conferencing, going to the client with the proper PPE, providing transportation, etc. But we're not a rich county. We're a poor county. We're a rural frontier county as far as the census is concerned. So our population is spread out.
First, I want to give kudos to Siskiyou County for ensuring that they are, you know, meeting the pandemic and not letting it kind of put everything at a standstill. And I have heard of other counties throughout the state ensuring that they're continuing engaging individuals and continuing their community planning processes by creating and adopting other platforms, virtual platforms, to ensure that we're able to not only continue client care, but to continue incorporating client voices in programming and policy decisions. Are there other comments?
I'm sorry, it's Yolanda again. It has raised the numbers of people with behavioral problems.
And I do want to say, Yolanda, to your point about how, you know, these surveys are really important. So our role was really, you know, and our hope to get out of this was just really find out, where are we today after, you know, MHSA passed in 04, started to become implemented in 05. Here we are, 2019. Where are we now as far as collecting and measuring recovery outcomes? And so it's really, although, you know, we do have a pandemic, our hope was to kind of push the pendulum forward and and get folks asking these questions and ensuring that we are adopting. And if we're not adopting, to adopt a meaningful recovery tool. We have the Moore's tool as an example that counties can adopt and implement. And if we're already doing that, we want to ensure that we're bringing our community stakeholders to the table and sharing these outcomes with them and using these outcomes in our decision-making forums. Robin Barney, I see your hand is up. You're on.
Good morning. One of the things that I'd like to bring up too is that I just think that it's so vitally important that we continue to keep our caregivers and our providers in the forefront as far as education goes. You know, because when we were looking at one of the slides and we saw the resources and how low that is, I'm sure it's even lower than that as we dig further into it. And you know, I think a lot of it too is because people, they find it easier to just give you the information or just help you instead of allowing you to be able to find things for yourself or help yourself, you know. And so it's also that thing too of being a co what's my word I'm looking for, um, when you want to take care of people. Okay, I don't know. I'm having a senior
okay.
moment here.
I think we get it though. And folks, for those of you that are not talking, if you can mute your phone because there's a lot of background noise.
Oh, I don't know what that. Oh, yeah, that's someone else.
All right. Thank you, Robin. Tashi, your hand is up. You're on.
Yeah, okay, so I apologize if Noah explained this better, and it was just that Susan was texting me, but pitfall number 2, the I don't trust them, the data will be used against me. As someone who definitely advocates for the collection of data, I'm not quite sure I understand the fear of the data being used against them, and in what, do you have examples, like in what way can data be used against somebody?
I don't have a specific example because I'm not a service provider, but I believe that Dr. Mark Ragins had specific examples that you might point towards. And I think it's an overall distrust of systemic processes, you know, because they don't know exactly if anybody is serving in their best interest, and trust is a level of thing, is something that's squishy and hard to pin down. So I think that's kind of where he was going with it, is just that why would we trust this to be any better?
So wait, is it the providers that are afraid to ask the questions because that data will be used against them as whether or not they're being successful as providers, or is it that the consumer or client doesn't want to give answers because they're afraid that they will be judged poorly for their ability to meet standards? I'm sorry, then I'm a little confused.
May I jump in? This, and I apologize for the interruption. This is Vernon Price from the Superior region. May I respectfully address that question or comment?
Go ahead,
Hello?
Vernon.
Okay, thank you. I'm speaking as a consumer of multiple services, not just the services rendered by a county, but private services through nonprofits. There are a lot of us consumers that are afraid to speak up for what the system is we are in now, receiving services, complaining about the services, about how we can improve the variables of the services provided. Number one of that factor of fear is losing the services that we already have. Number two, of being asked if we've taken our medications, because at that point planting seeds in other people's minds that are at the table that can improve the quality of services that directly improve the quality of life, plants the seed in those minds that a person is unstable when they ask that question. So the fear of judgment and being reduced to one's diagnosis instead of the person being seen as a whole individual is the second fear factor. And the stereotype and stigma that comes along with the lived experience without the understanding at the table. Is that too confusing, or am I making sense, or am I just having a moment?
No, I think you're making sense a little bit, and I think this is a deeper discussion than we can have at 11:06 a.m.
Okay.
Luckily, I have access to the access team, so I'll let them go on to other people, but I really, really appreciate that. Thank you.
Okay.
So I do want to let folks know that you have our contact information that's up on your screen right now. We do want to honor the time, and if you would like to log off now, you're more than welcome to. But Noah and I can stick around for longer if folks have any additional questions or comments. And if not, we hope you have a wonderful weekend and stay well, everyone. Thank you so much for joining us today.
Andrea?
Yes.
This is Vernon. I understand you may have an extremely busy day, but if you can give me a call on my cell at your earliest convenience, that would be greatly appreciated.
I would be happy to. Thank you.
Thank you.
You got it, Vernon. And I see Robin came up with a word. It was codependent. You go, girl. So she was saying her word was codependent, and her resource team needs to be continuously updated, or her resource system, excuse me. Not having an updated system slows down the process. Absolutely. Thank you all so much for joining us. Have a wonderful afternoon. Bye.
Okay.